Okay, so as part of the session, we wanted to have a panel discussion. So we're a little bit of a smaller group right now, but I think there are some very burning questions about how you develop these therapies. So I invite Rick up here. I'll ask a couple of questions to get everybody started, but I'll then encourage the audience to join the conversation. So I think it's interesting maybe to start with a question around reimbursement and this challenge of, right now we're dealing with fairly small indications, and so I think the payers are pretty permissive in terms of supporting this therapy. There is some discussion around NTAP, which is this new technology add-on payment to help cover the costs of these therapies. But there was an article that just came out in JCO a couple weeks ago, you may have seen, which was just sounding a little bit of an alarm bell of, well, as we start rolling these therapies out, as we start to get traction in solid tumors and so forth, it is actually a cost burden that the system can't support. And then of course, Carl, raised that physician who said his costs were $500,000, even though his treatment was free. So how could you guys comment on how do you see the payer system evolving? And Rick, for you, I think it's about how do we see this technology, the manufacturing technology, the cost of goods and so forth evolve over time, and how do we roll that through clinical development to next gen improvements? So maybe start with you.
Yeah.
Maybe just start with you, Henning.
So, that's a very challenging topic right now. It's evolving somewhat rapidly, I believe. NTAP could be an improvement, but like I said, I don't think that's going to be the end solution. Another part of that payer ad board was discussing where CAR T therapies go over time. And the alarm bell sounded with a lot of the payers when we started talking about first-line utilization. The numbers obviously get very large there, and that's where the system costs may become prohibitive. That modeling isn't really done from my perspective, and there's a lot more to do there. Value-based contracting, outcomes-based contracting, again, really difficult to pull off. May not really work. Within a pediatric ALL population, makes tons of sense, and it's doable, 300 patients per year or so. But as you look into really large populations in other hematologic diseases, not sure where the system goes with that. So, Rick, I don't know.
Yeah, so just to address the question about manufacturing the cost of goods, I mean, clearly that is an additional challenge, but I think there's a lot of progress being made. The big players early on, rightly so, identified the need to have commercial facilities to produce these products. Everything is beginning to scale. We know how to make the viral vectors at large scale now, and that will drive down the cost. The commercial manufacturing times are being shortened. Everyone involved is sort of getting their supply chains ducks in a row. So I do see that trending down as we figure out the reimbursement. So, but certainly a significant part of the therapy is eventually going to be the non-product cost, and how do you deal with that?
So what are those associated costs? This is a follow-up question. Do they differ across, I mean, right now everything's CD19 CAR, but we can get a view into what additional costs might be in some of the other emerging therapies. Is it the same? Is it toxicity and management? Is that the main driver, or?
Yeah, so looking at the existing commercial products, I don't know that there's a significant amount of differentiation there. And when you look at the cost of TOCI and hospitalization costs broadly, I think time will tell what the actual commercial setting costs look like. But right now they seem very significant for a lot of patients. and the incidence of significant tox is a big part of the current profile. This is such a rapidly evolving space. I have a lot of confidence that subsequent versions of CAR T technologies are going to significantly change that equation, and I think AE profiles today will look very different in 2 years, 5 years. And I think access and total cost to system will likely evolve in the right direction because of that.
Yeah, I mean, as Carl pointed out, we're now starting to understand even what the potential success of the T-cell product, patient material coming in, and how that can relate. So when you start to get that kind of information, you then can actually, I think, be a little more diligent about how the product is applied, and potentially and just give it to the the people you can potentially will have that greater benefit.
Yeah. Okay. So are there any burning questions from the audience for the panel?
Sorry, I am curious about the clinical trial, the cost of a clinical trial per patients. And just like this kind of technology is very advanced, we all know we need to pursue unmet medical need. But in considering, because it's so advanced technology, so how you decide go and not go decision, how you make this balance, especially you haven't figured out the insurance part, and how you pursue insurance company that then buy in this idea to pay it. Otherwise, nobody can afford it.
No, you for.
I guess that's a question around when do you start talking to the payers, and how do you fit that information in with your decision to move forward with a BLA? And I think the CD19 CAR is an interesting case, because I think, it seems to me that in the case of CD19 CAR, that wasn't well mapped out. I think there's different models between Yescarta and Kymriah. I never know if I'm saying that right, but in how they get reimbursement, but both have challenges, right?
Yeah, I think it's pretty clear there's a lot of challenges with the whole class of products right now. And the engagement with payers and the government happened very early on. It didn't start well, but like I said, I think it's accelerating. I think it's improving. A lot of the centers we've spoken to in the last couple of months are saying that they're having to negotiate every individual patient, but they're successful in most cases. They're also being pretty selective in the patients that they're identifying as well. They're trying to make sure the right patients are stepping into this. And there's a lot of different factors between tumor burden and other issues that will drive your decision making around that. But overall, I think it's starting to move the right direction, and the system will have to find a way to absorb the cost. These are ultimately therapies that are so game-changing that we have to find a way to make it happen. There's some interesting ethical questions within that too, ultimately relative to utilization of chemo regimens. We've done a lot of patient studies, and we find that going through R-CHOP, RICE, BR, these are very difficult things. And I think sometimes the physician doesn't recognize how significant that journey can be for patients. But when you sit down and talk to those patients, it can be absolutely debilitating to the point where they don't actually want to even try a new therapy. So that ethical question around, where does CAR T therapy fit, first line, second line, relative to other available treatments, is going to come to the fore, I think, pretty quickly.
I mean, Gwen, you were talking about, before the session started, about how the patients, respond to these therapies and how different it is versus standard chemotherapy. We've had patients, come in to see their physician, and after the anti-BCMA CAR therapy, and the physician will ask, what medication are you on? And they say nothing.
Right.
And it's like, well, you actually are. They're just living inside your body, and just so the patient, the experience is very, very different. But again, as you pointed out, I mean, the pace at which we've gone from these academic studies to licensed products, caught all of us by surprise. And we're playing catch up. I mean, Henning's trying the best he can to actually get the academics to figure out, that this is more than an experiment now.
Oh, so we have a question up here on the microphone, please, if you could turn it on.
There you go.
Yeah, so I was just thinking that in this particular field of medicine, this is not such a game changer in a way, because you had previously stem cell transplantations that came in, which also are not for free. Yeah. Yesterday we heard a figure, I guess it's not easy to make that comparison, but it was mentioned that in hemophilia, that if you do the gene therapy thing and if you count the costs for maintenance treatment, quite rapidly you will actually get that returned. Mm-hmm. It's a bit different, I guess, in leukemias where people die, so there are no further costs.
Mm-hmm. Yeah, so thank you for that point. I actually wanted to revisit exactly that same point that you made, which is you said that the payers started to have alarm bells when we start talking about first-line administration for these engineered T-cell therapies, but the flip side is what the speaker just mentioned, which is, what about all of the costs that go into managing a cancer patient through multiple rounds of chemotherapy and toxicity management? Yeah. And have you ever looked at that, those cost savings, and fit that into the payer equation?
I think ultimately that is certainly a part of that conversation. And the costs are very significant as you look at patients who've gone through 3-4 lines of therapy. So it may make sense. When I speak to groundbreaking, to me it's this combination of response rates, single dose, relative to the existing patient populations we're looking at. And if you expand that out, this could change the face of oncology in a lot of ways. We'll see about solid tumor. If you go out and speak to a lot of clinicians today, they see it that way. And they want to be on the front line of using these therapies. A lot of them want to get away from chemo. They don't want to be using chemo. It's really rough stuff with relatively limited efficacy. This looks dramatically better to them. And yeah, there are some analogs. It's not the first time we've come across things like this. But looking at the technology and thinking about where it could go, I think a lot of folks think this is a turning point.
So while we're on the topic of cost, I actually have two related questions. One, kind of piggybacking on the last question or comment, do you see a reduction or an elimination, virtual elimination of requirements for transplantation as a result of CAR T-cell therapy applied to patients who otherwise may have, overwhelming chemo and wiping out the bone marrow and transplant? So that's question one. The other question is, there's been a change in the 340B program lately where hospitals cannot benefit from it like they used to. How are you seeing that affect CAR T-cell therapy?
So I'll let you answer the 340B question. But so what's interesting is that, physicians transplant a fair number of patients with the knowledge that these high-risk patients are going to relapse, and they still bring them to transplant. I mean, rightly, ethically so. I mean, but they know, based on their cytogenetics or their other profiles, those patients will relapse. So I think you need to start to think about these therapies as an alternative to those high-risk patients, which the transplant's just going to give a little bit of time. And that potentially will then cut into the overall cost of that patient management substantially. So there's certainly, I think that's something that is something to throw out there in the equation.
Yeah, and just to add on to that, as we look at that, the story it's too early at this point to really know that. As we go through more clinical studies and more actual commercial practice, we'll learn more about that and the health economics elements of this, and really understanding how far upline this goes and who the right patient for CAR T is. That'll evolve with time. We've certainly looked at some models where it does in a lot of ways replace transplant, but I don't think it's in any way a certainty at this point in time. There's still value on that side of the fence. And then 340B, broadly, we don't think that's going to have a big impact, a dramatic impact on CAR T overall. It's certainly a challenge for specific institutions, but we don't look at it as a big concern.
So I wonder if we can switch gears a little bit away from the reimbursement. I think that's been really nice coverage of some of the challenges we have, and there's a lot of outstanding questions that will stay tuned. This, so going back to the concept that this therapy can be developed extremely rapidly, and part of the reason for that is because we see dramatic anti-tumor responses, and so that also then leads to the ability to have much smaller pivotal studies that can lead to approvals. And then it follows that there might be, the way I look at it is I think there's going to be a continuous sort of sea of next generation products coming through that will be, at least for the near term, constantly displacing the products we have in the market. And I was wondering if both of you could comment on how you see that happening from a regulatory perspective, and how you think that, if you see any challenges you already have, something on the market that you know is working, what needs to be done in order to actually get an improvement out there that people are comfortable with, and how do we roll in, again, these manufacturing improvements that will help bring down cost of goods as well?
So, we're almost before we put our, our first anti-BCMA CAR into the, patients, we were working on what could be done from a manufacturing standpoint to increase the efficacy of that product. And we were actually prepared, and actually last September we started essentially a new second generation product, which has a manufacturing change, which gives us some more of these memory cells, which may give you more longer a response. And the actual regulatory path of a manufacturing change where this potentially could lead to, it's a shorter process, so you can cut costs there, and if the durability is more, you can again think about moving it lower in lines of therapy. I think we have to continue all the companies have to continue to look at that. Now, I think it's certainly going to be challenging if CAR T-cell therapies or TCR therapies start to then be one after another. So if you fail Yescarta, will you then go on in combination anti-CD19, anti-CD22? I see that as actually being, we think it's hard now to go to the well with caustic therapy. It's going to be very difficult when we start to go that well more than once, even though clearly there would be clinical rationale to do that.
Yeah, and commercially, I think it's fantastic for patients. It's incredibly exciting. Being a part of launching CAR T therapies, that dynamic nature makes it actually a lot of fun. On the other end of it, you have something coming on the heels of what you're rolling out, so it can be a little bit daunting as well. It's just a very intense environment, and I think looking out over the next 5 years, the pace of innovation is going to be so dramatic that in a commercial setting you're going to be constantly busy, and the intensity level is certainly going to be higher. But in the end, I think it's just fantastic for patients and broadly anyone affected by these diseases should be looking forward to what's coming. This first set of products are amazing, and even better therapeutics are coming along the way now.
Okay. Any other questions from the audience? Do you guys have any burning questions? I have some other, but they were sort of covered in the talk, so yeah. All right, well, thank you very much for your time, and
Thanks, everyone.
thank you all for staying for the panel.